Good morning, everyone, and happy Friday. Welcome to today's session of the COVID-19 Changing the Way We Work Community of Practice. I'm Eleanor College. I'm a family doctor. I work in East Toronto. I'm also the CPD Program Director for the Department of Family and Community Medicine at the University of Toronto, and delighted that we can continue to offer you these sessions in partnership with the Ontario College of Family Physicians. And today we'll be focusing on an update about COVID, measles, and supporting primary care. And I'd like to turn it over now to Dr. Mehala Kumanen from the OCFP to open the session.
Thanks, Eleanor. Good morning, everyone. Welcome. We have a great session lined up today, and I wanted to just take a moment to thank our speakers for being here with us. And a reminder to all of you that this is a Maine Pro accredited session, and details will follow by email. Next slide. So just moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous peoples have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Next slide, please. So I just wanted to take a moment to reflect. This is an article that I stumbled upon that essentially touches on the disproportionate representation of Indigenous people in Canada's homeless population. And when I read it, it made me think about some of the factors that have contributed to this issue. The article quotes a housing advocate who essentially spoke about the importance of cultural inclusivity when we're looking at solutions to the housing crisis. And she used the example of, in some cases, people get evicted when they are smudging as one of their cultural practices. And she really emphasized the need to bring a more inclusive lens to the housing crisis. So for me, when I was reflecting on this, I think it just reinforced some of the systemic barriers that we know Indigenous people face. And in this example, those barriers are essentially contributing to inequities in social determinants of health. So it just reminded me as a provider that we need to be aware of this and really keep it top of mind when we're working to support our Indigenous patients in their health and well-being. Next slide. You're on mute there, Eleanor.
Had to do it once this year. Just a reminder that this session is part of a series of sessions which are all available online and are all accredited. So a really lovely way to get your Maine Pro credits. Next slide. And these are our speakers for today. I'm going to ask them to introduce themselves in just a moment. Next slide. So now I'll ask them to each introduce themselves and just speak to their conflicts of interest. Dr. Megan Devlin.
Hi guys, thanks so much for having me. I am an infectious disease physician who practices in London, Ontario. I'm also an assistant professor at Western University. And I've been responsible for starting an acute virtual COVID clinic here in London, as well as a long COVID clinic. And my disclosures today are that I have received some honoraria for speaking from Pfizer, ViiV, and OCFP.
Thanks, Megan. Dr. Liz Mugga.
Good morning, everybody. Great to be here. And I'm Liz. I'm a family doctor in Ottawa, and I also have the role of senior clinical advisor to primary care at Ontario Health, and I receive a stipend for doing that role. Thanks.
And Dr. Kumanen.
Hi there, everyone. My name is Mehala Kumanen. I'm a family doc in Cambridge. I currently serve as a Deputy Chief of Family Medicine at the Cambridge Memorial Hospital, as well as the President of the Ontario College of Family Physicians, and I receive a stipend for both roles, neither of which poses a conflict for today.
Great, thanks, Mehala. And I've already introduced myself, and other than receiving an honoraria, which I don't think poses any conflict here, I don't have any other financial sponsors. Next slide. So just a reminder on how to participate. I see there are already some questions coming in, which is fantastic. Please post your questions in the Q&A and use the chat to share your resources and network with others on the session. But just make sure that your questions go into the Q&A. And also, if you see a question that you really like, please give it a thumbs up so that it gets upvoted, because I'll prioritize these questions when I'm moderating the session. And I think that's it in terms of the nuts and bolts of the session. Next slide, please. So today we're going to start with Megan, and then our second speaker will be Liz. We'll have a Q&A after Megan's session, then another one after we hear from Liz, and plan to complete most of or all of the content by 9 a.m. But we will be around for Q&A between 9 and 9:15 if more questions come up. All right, let me turn things over to Megan.
Great. All right. Well, we'll get right into it. Next slide. So today I'm going to review for you guys how we are looking in Ontario with regards to our respiratory viruses. And then I'm going to share a couple of studies around COVID vaccination that were just recently published, and I think will help you guys in terms of your discussions with patients around ongoing COVID vaccination. And then measles is hot right now, unfortunately, so we're going to take the last few minutes to speak about measles. Next slide. So of course, our most sensitive way of knowing what's happening with COVID in the community is looking at our wastewater signal. We can see here in Ontario that through the months of December and January, we had a peak of cases, but through February, we are going to see a decline. The one exception to that is if you are in the northwest area of the province, so in the Thunder Bay area, there does seem to be a bit of a U-shaped curve, and so we may see an increase in cases in that area. Next slide. So our other respiratory viruses as well, we look at our test positivity rate, so people coming in with respiratory symptoms and what percentage of our tests are positive. And right now for both COVID and influenza, our numbers are below 10%. So about 9.2% for COVID and influenza about 7.5%. So this is very this is nice for us to see. However, I know many people will be planning, or your patients will be planning to travel over March break. And particularly if you're going to the United States, I do encourage you to look at the rates in the states you may be going to, as their rates of COVID and influenza are much higher than what we're seeing here. Next slide. I know many of you work in long-term care facilities or provide support to them. And so Public Health Ontario has just had a look at our outbreaks of respiratory viruses over the winter months. So what we can see here in the top section is that the blue bars represent our COVID outbreaks, and there's been fairly consistent numbers regardless of the month. And then through the winter months, we have our influenza in our green bars and RSV outbreaks in our yellow bars becoming more prevalent in the winter months. And this is not a benign thing. It is associated with morbidity and mortality. So for COVID alone in the winter months, I think we've seen over 500 admissions to hospital and over 300 deaths related to COVID. So again, whatever support being provided to our long-term care, we really appreciate the work that you guys do. Next slide. A few of you had questions about what our numbers looked like this time last year. So we can see here in the blue dots, the decline in COVID cases that we have seen over the last month or so. And when we look at the yellow bars, that's the 2022-2023 season, there's certainly been a decline in cases over the spring months. A lot of factors, though, will contribute to that. So next slide. So with that, a few of you have had questions about whether or not we should be recommending spring boosters. And we do have some guidance that was provided by NACI in January, recommending that patients, and again, the operative word here is may receive a booster of our XBB monovalent vaccine, particularly if they're from a high-risk group. Personally, this is not something that I'm blanket recommending to my patients, but on a case-by-case basis, particularly if my patient is very high risk, maybe traveling, and is keen to get the vaccine, then I I think it's reasonable for them to receive their vaccine. Next slide. How did our vaccines perform this winter? Well, we have a little bit of data that comes out of the States from this winter. And this is looking at people who presented to either a Walgreens or a CVS pharmacy with symptoms and got a COVID test. We looked at the odds of vaccination, or those who tested positive and those who tested negative. And what we found is that there was about 54% vaccine effectiveness in preventing symptomatic disease. So not bad, not great, but not bad. What I do want to note here is that the circulating variant this winter has primarily been JN.1, while the vaccine is the XBB monovalent vaccine. And there was still protection. So we're still working within the Omicron lineage of this virus, and there was still a benefit to receiving vaccination this winter. Next slide. Another study I just wanted to draw your attention to, particularly if you're having conversations with your pregnant patients around COVID vaccination. This is a very large cohort study out of Sweden and Norway, looking at women who received an mRNA vaccination during pregnancy, and then looking at neonatal outcomes. And what they found is that there was no risk of adverse neonatal outcomes if they received the vaccination. And in fact, you can see here in the yellow bars, there did appear to be a benefit to receiving the vaccine. So I think if you have a patient who might be on the fence or is a bit concerned, you can point to this study, which is adding to our sort of growing body of literature around vaccination and pregnancy being a safe and important intervention. Next slide. Measles. Oh no. You may have seen reports in the media, particularly in the last 2 or 3 weeks, alerting us to have concern about measles. And when we look at our 2023 numbers worldwide, there certainly has been an increase in cases compared to 2022. And unsurprisingly, this is in countries where the public health system may be less robust, and we're likely going to see lower MMR vaccination rates. So you can see on the sidebar here, worldwide countries that had high numbers of measles cases in 2023, and you may have patients either immigrating from these countries or traveling to visit family. And so just to be aware of that if they are planning to travel. Not only though, sorry, we'll go to the next slide. So how is North America doing in 2024? Well, in Canada so far, we have had 4 cases, 2 in Ontario, so 1 in Toronto, 1 in Peel region, 1 in Quebec, and 1 in Saskatchewan. And at least one of those cases was hospitalized. We also have seen a number of cases in the United States, and one to add to this list is there is an outbreak right now at a school in Florida in Fort Lauderdale with 6 cases associated with it. So this is something for us and to be aware of. Next slide. Now, for those of us who may have never seen, younger doctors who've never seen a case of measles before, just a bit of a refresher. Reminding ourselves that this is one of our most highly infectious agents. So if if we have a population that is susceptible to the virus and they are exposed to a patient with measles, about 90% of people will become infected. We say that typically we want to see 95% vaccination rates. And here in Ontario, we're doing a relatively good job of maintaining those rates. I'll talk about that more in a bit if there are questions around that. However, if a patient is exposed to measles, the incubation period is about 10 days, but can be anywhere from 7 to 21 days. And often their initial symptoms will seem like a cold, so they may just have fevers to start with. They'll have the 3 C's that you may recall from medical school, so cough, conjunctivitis, and coryza, and you may see the Koplik spots on the inner buccal membrane. Typically, as you may recall, the rash starts in the face and then spreads to the rest of the body. And then our big concern with measles is the morbidity that's associated with it, particularly secondary bacterial infections and other neurologic complications like encephalitis. Next slide. So If you're wondering who is immune, basically, if your patient has received 2 doses of MMR vaccination, that should be adequate. In Canada, our vaccination campaign initially started in 1983, and then the second dose was included in 1996. So we have adults born on or after 1970, they should receive 1 dose of MMR unless they are from a high-risk group. And if we work in healthcare, we should have received 2 doses of the vaccine, but there are other high-risk groups that I have mentioned here. If you are born before 1970, you are presumed to have been exposed to measles. However, again, if you are in a high-risk group, you may consider additional doses. And if this seems a little bit confusing, there is much more clarity in a few slides. I tried to make it as simple as possible, but there's more nuanced discussion for each particular case. Next slide. So what do you do if you're concerned about a patient who has traveled, may have been exposed to measles or has symptoms with measles? Well, first is to recall that this is airborne transmission. So you may want to do your assessment over the phone. And if you're advising that a patient goes to the emergency department, that you call ahead so the emergency department knows to put that patient in an airborne room. If you're collecting specimens, we can do either a nasopharyngeal or a throat swab, or collect urine for PCR. We also can send serology, but that may be a false negative in the early stages of the infection. And just to recall, we are able to give post-exposure prophylaxis. So if it's in 72 hours and they are able to receive an MMR vaccine, they can receive that. If it's past that point, or they are immunocompromised or pregnant and may be susceptible, then you have up to 6 days to give human immunoglobulin. Next slide. So I'm happy to answer more questions about measles or COVID, but just wanted to provide you guys a bit of an update about where we are at with regards to both of these viruses, which, as you guys point out, are vaccine preventable, and you guys have done an amazing job in making sure our population remains well vaccinated.
Thanks so much, Megan, for bringing us both up to date on COVID and also reminding us about cough, coryza, and conjunctivitis, which I feel like I remember from 20 years ago or 30 years ago in med school for measles. Just going to speak to these slides here. These are some resources around measles. And also I noticed in the chat we posted a link to Dr. Moore's statement around measles that was sent out last week. So certainly check that out, and we'll put it in the resources that we send around after the session. Next slide. And this was just, I wanted to pop this in because we talked about long COVID at our last session, and Megan, I know you were involved in the setting up of this long COVID clinic. So just another resource for physicians that may be working in the London Middlesex area if they're looking for somewhere to send their patients with long COVID symptoms. And then I think we can put the slides down if you don't mind, Susan, and move to questions. So lots of questions have come in. First off, just questions around the rapid tests. So where to get the COVID rat tests, because many of them have expired or will expire soon. And just wondering if there's if you know if there's any official Health Canada extension of expiry dates for the current kits.
Yeah, so I think Dr. McGeer addressed this at one of the earlier sessions a few months ago, and that our early COVID tests, there was an extension in terms of expiration dates. I don't know the exact dates of that, but if you go back to her session, you will be able to find that answer. In terms of where to get our COVID tests, I don't have a specific answer on that either, but I'm not sure if pharmacies are still giving out free tests.
Yeah, thanks, Megan. I think it might vary where you are. Like I know in Toronto, sometimes we can access them from the public health clinics, but we'll check into the resources in terms of where you can access them locally, include that after the fact. In terms of another question, actually switching over to measles, mumps, and rubella, question here, should older adults or those born prior to 1970 get an MMR booster?
So short answer to that question is not necessarily, or no. If they have been exposed to measles, then they do not need a booster. However, if you go back to my slides on that, if they are planning to travel, then it would be reasonable to consider a booster.
Great. So if someone's traveling to an area where there might be a measles outbreak, then you could consider a booster in those circumstances?
Correct, yes.
Excellent. Another question around, I'm sorry, I'm just looking through the questions here. I think there's another question around measles boosters, which we've just answered. So another question around COVID and long-term effects, and we did speak about long COVID last session, but I'll pose this to you, given that you also work in that area. Although there are studies, although studies are in the early days to say what the long-term effects of COVID are, based on your expertise with other viruses, what are your thoughts regarding risk of cancer, autoimmune disease, diabetes, cardiovascular disease, organ damage, dementia with repeated COVID infections? We as family doctors are going to experience the consequences of caring for this tsunami that's coming.
Yeah, so I think it's a very good question. With sort of the long COVID clinic, we see a number of referrals for different symptom clusters, and Dr. Quinn spoke about some of those different symptom clusters last time. However, there is this concern, particularly around metabolic diseases like diabetes being more prevalent. I think we need to see larger population-based studies to see if this is truly what's happening. But when you are assessing a patient with long COVID or symptoms that you're concerned may be long COVID, I also have provided a few slides on what tests we can consider doing before referring them to our long COVID clinic. And of course, that is going to include looking for things like hypothyroidism, diabetes, etc. And I think, yeah, it's going to be a big team effort in caring for patients who are dealing with the consequences of their COVID illness.
Thanks, Megan. So I'm switching you back and forth between COVID and measles just to keep you on your toes here. So another question regarding, should older adults get a measles vaccine when their vaccination history is unclear? It was so long ago, and is there any risk in having the vaccine for older adults?
Yeah, that's a great question. So often we're faced with patients who have immigrated from a place where they don't have great vaccination records, or again, an older patient who doesn't know their vaccination history. So it's the situation could be you could send a measles immunoglobulin IgG level to see if it's reactive, and if it is, then that confirms immunity. There is no harm though in giving additional doses. So I have patients who have immigrated, don't have a great vaccination records, and I don't see a harm in giving them additional doses of MMR vaccine. There's no harm to that.
And perhaps a follow-up to that, just because there was this question around the MMR booster, would it come out of the public health supply if you are boosting somebody as an adult or somebody that was born before 1970?
That's a great question, and I don't know the answer to that. I assume yes, but I don't know.
Okay, I feel like I assume yes too, but we'll check into that. But my assumption would be that yes, you can provide it out of the public health supply, but we'll confirm that. Another question just in terms of measles. So if we see a case of measles in our office, how do we handle this when we have a waiting room full of people and ever increasing numbers of unvaccinated children in our practices?
Yeah, that's a great question. So if you are concerned about measles, then of course you would want to put that patient into their own room, and as quickly as possible, try to contact public health for further support. And again, there's lots of resources online about contacting your local public health authority. This is an airborne virus, which means that it can hang in the air in your office for up to 2 hours after. So another recommendation would be, if you are planning to see a patient in your office, you see them at the end of the day. But I know a number of you may feel that that's not able to be accommodated in your clinic. So public health would be following up in those situations.
Thanks, Megan. Wondering, there's a question just around how can you review how the measles rash differs from other viral exanthems?
Yeah, so that's a great question. And I'll be honest, I haven't seen a case of measles. I've talked to providers on the phone who have seen active measles. So usually the rash is described as sort of a macular papular rash. At the very beginning, starts in the face, and it can be blanchable. But the rash, when we compare it to other viral exanthems, tends to last a lot longer. So it can last up to 10 days, whereas another viral exanthem usually will last sort of 3 to 5 days. As you guys, as family doctors, probably have seen a lot more pediatric rashes than I have in your practice. So I also welcome if anyone is typing into the chat and has additional advice, I encourage them to do that.
Thanks, Megan. Another question regarding measles. This attendee mentions that I've been seeing young adults who've received 2 doses of MMR in childhood, but are not immune by serology to measles or mumps as young adults, because I guess serology was checked for university college admission.
Yeah.
Should we be checking young adults for MMR immunity routinely and boosting if they're not immune?
Yeah, so that's an excellent question. I sort of went down a rabbit hole looking into this, but basically there will be a decline in serologic titers over time, particularly if you were vaccinated versus you actually had measles. It does not necessarily mean that that patient is non-immune. So there may be a T cell response that occurs that isn't seen in that antibody level. We have done a lot of population-based studies looking at seroprevalence in our population, particularly our young Ontario population. And usually we're sitting about 90% seropositivity. So these patients don't necessarily need a booster. However, if they may be working in a healthcare setting, it may be more beneficial to consider a booster.
Okay, so if I understand correctly, you're saying the serology might come back negative, but they could still be immune.
Mm-hmm.
And you could boost them or not in that circumstance?
Yes, I'm giving you I think if they're working in a high-risk setting, like in healthcare, then certainly I would recommend a booster in that situation. But it's not mandatory. And if you look at your immunity factors, having received 2 doses is adequate.
Great, thanks, Megan. And actually just wanted to confirm that we did hear that in terms of the public supply, yes, you can boost out of the public supply. So I wanted to just say that out loud for those people that are out on a walk and listening. If you need to boost your patients, then you can take them from public supply. Another question we have here is, can we immunize 6 to 12 months who's traveling from the Ontario Public Health Supply? Oh, or do we need to charge for non-OHIP as for travel? I'm aware they would still need 3 MMR vaccines eventually to stay immunized according to public health.
Again, I'm not sure the answer to those questions. I would assume yes, because you are giving them that first dose, and it is recommended that you can go as low as 6 months to receive that vaccination if they're traveling.
Yeah, and I think my understanding is they would still then have their 2 doses after they were 12 months old. Is that correct?
That's correct, yeah.
Another question here from Jenny. Are you concerned about us seeing a decline in benefit immune response with frequent immunizations? And I'm sorry, this is switching back to COVID, I believe, i.e. giving vaccinations every 6 months.
Yeah, so I think, as I alluded to, the Q6 monthly dosing of COVID vaccine is probably not for everyone. And time will tell if sort of annual vaccination is beneficial. It may look like influenza vaccine, where we're going to see different vaccine effectiveness every season. But I certainly am not recommending Q6 monthly vaccination for all of my patients unless they are sort of very keen to get it done.
Excellent. Thanks, Megan. A question actually around measles and awareness. So are the pharmacists being made aware of this concern of measles? I'm getting more reports from pharmacists that they treated conjunctivitis as a bacterial infection, but more likely to be viral, and I guess could be measles. Any thoughts on that?
Yeah, that's a great question. I think hopefully our pharmacists are organizing on this front. I don't know what the public health outreach and sort of media outreach looks like to them. So I can't really speak to that easily.
Thanks, Megan. Another question around the subpopulation. So measles revaccination recommendations for patients after stem cell transplants or bone marrow transplant, or if they're on chemotherapy, should they get one shot or two?
Ooh, that's a great question, and one that I would have to make sure I refresh so I'm giving you an accurate answer. So usually for patients who are post stem cell transplant, it is quite some time before that it's safe to give them an MMR vaccine. And I think at least a year, but I would have to look into that for sure. So I can't give you a direct answer.
No worries. Thanks, Megan. It is certainly a specific group, and sounds like what you're saying is this is something where you'd have to check on the guidelines to see what the recommendations are for that specific population. A question switching back to COVID. With decreased COVID rates, is it reasonable to stop masking in the office setting?
Yeah, that's a great question, and one I would sort of refer you to your public health guidance around that. Certainly in our hospital setting, we're continuing to mask inpatient interactions. But over the summer last year, we did not mask over the summer months. So again, just recommend that you refer to your local public health guidance around that. I think right now that it's continuing to mask is a great idea. And I think Kieran Moore is in the chat, so he may be able to answer that question as well.
Thanks, Megan. It's a question that keeps coming up because I guess it is challenging when the rates are going up and going down. A question from Helen Batty. There was a problem with ineffective failed vaccine MMR infants in the 1982 to 1984. There was an attempt a decade later to find these children and revaccinate. Are there many of these adults now, approximately 40, at risk again in Ontario?
That's a great question. I think if you're looking at seroprevalence studies, we still have very high rates of seropositivity in our population up to the age of 40. And so I don't think that there is a significant risk, but again, I don't know this in detail.
Thanks, Megan. A question regarding long COVID clinics in the GTA. Many have closed due to funding. Not sure if you're aware of those that might still be here.
Sorry, what exactly is the question?
I think the question is whether you're aware of long COVID clinics in the GTA, because many have closed due to funding.
I see. I can't speak to that. Dr. Quinn would probably be the person to reach out to around that. But certainly in London, ours is still running. I don't want to have a flood of referrals, but we are accepting patients outside of London area now, but they have to be willing to travel to London for their assessment.
Thanks, Megan. Just looking over some of the other questions that have come up. In terms of measles, boosters for travelers born prior to 1970, are they required if they've been tested and found to have immunity in the past or have had measles in the past? I think we spoke to this a minute ago, but just wanted to confirm.
Yeah, I want to give a clear answer, and I would say if there's clear evidence of immunity, a booster is not necessary.
Excellent. And just because we have asked you a bunch of questions, some of which may not be in your purview in terms of the public health supply of vaccines, we will certainly look into this and get back to our attendees and provide those resources when we send out our session, our information after the session. So thank you for answering all these questions, Megan, and I would encourage you, if there are some that you can answer when we move on to our next speaker, that would be wonderful. But thanks for updating us and for answering the many questions that we've asked of you, and we'll bring you back in a little bit.
Great, thank you.
Excellent. Maybe you can bring up the slides again. So with a great deal of pleasure, I'm now just going to introduce our second speaker, who probably doesn't need much of an introduction for most of you because she's had many hours on the COVID community of practice. Anyway, really looking forward to hearing from her, as we know that there's a lot changing in primary care, and it's often a bit challenging and confusing to figure out who does what. So we're looking forward to sort of the ABCs of delivery of care here. And also some updates from Ontario and Health on the sort of work that they're doing to support us in our work. Turning it over to you, Liz.
Great, thank you so much. Thanks for that introduction. And it is really nice to be back here, although I do join in the background for my CME as well. So, but nice to be a panelist. So if you go to the next slide, I really wanted to start here in my remarks about the foundational role of primary care and the family doctor within that primary care sector and the work that we do. And I don't need to tell this group that, of course, this is an incredibly challenging time for us to be family doctors, to be working in primary care for so many reasons. And some of that can be bundled up to talking about just the working conditions being incredibly challenging. And at the same time, I know that we came here because of what we care about, right? I mean, I think we hold in our hands at the same time the fact that the work that we do is meaningful, it is foundational, it is what we know is required for high-performing healthcare systems. We care about the relationships. We like doing the diversity of work. So these two things are present at the same time. And when I joined Ontario Health now 18 months ago, I was really excited about the opportunity to support Ontario Health in advancing primary care, and that's work that we do in collaboration with the ministry. And when Eleanor and the team, Mahale, and asked me to come and speak about, tell me exactly what you're doing at Ontario Health. We don't, most people wouldn't know. You're a new agency. How is it different than the ministry? How do you connect with stakeholders? Sort of the ABCs. I was delighted to do so because I think that there is a path forward that we're building to support primary care. There's a journey that we're on, and there have been some recent announcements. And so, I think we're going to hold that tension together through my talk and the challenge that it is. And I also think the opportunity that sits before us for some advancement and change in our sector. So next slide. So this is Ontario Health. We were formed as an agency in 2019. It's a Crown agency. And the responsibility of Ontario Health, really in kind of a sort of short, snappy summary, is that we're responsible for overseeing healthcare delivery and health service integration. And that's different than what the ministry does. The ministry is responsible for setting the policy and the strategic direction, and they are the funder. So we work very closely with the ministry, particularly within the ministry. They have a primary healthcare branch. And I'll show you in a moment where primary care sits within Ontario Health. But our work is around implementation, integration, delivery of care. Ontario Health pulled together 22 legacy agencies. So the 14 LHINs came into Ontario Health. We now have 6 regions. The clinical agencies, you would, I'm sure, be familiar with agencies like Cancer Care Ontario, the Renal Network. Health Quality Ontario sits within Ontario Health, Health 811, the regional virtual care clinics. So all of that sits in Ontario Health. And one of the key pieces as it relates to primary care that is with the ministry, in addition to what I mentioned around the ministry being the funder, the ministry setting the strategic vision, is that physician remuneration and negotiations sit with the ministry. So that piece is with the ministry, as well as the provincial health workforce planning on primary care, education and training. So when we think about funding medical schools and nursing schools and how all of that plays into primary care, that sits with the ministry. And these are our, you can kind of see some of our vision, mission, and values there. So this is the org chart, and I don't want to get too inside baseball for you, but I thought important to call it a couple of pieces here. One, as I said, is our regional approach. So the regions are really our core partners, and when we're talking about the delivery and the implementation of care, and so each of you works within one of these regions. And then primary care sits, you can see over on the right, there is one of the core portfolios within Ontario Health is population health. And then the orange box at the bottom of that is primary care. And so my down the hall neighbors, so to speak, are within Ontario Health are the teams that work on preventative care, that work on the Ontario Health teams. And so some really great synergies in the organization in terms of where we sit and the work that we do. Another really important part of Ontario Health is that it's a clinical agency. And so there are over 100 clinicians, including physicians, also nurses who work throughout the agencies to provide that clinical approach. And there are hundreds more, and many, perhaps some of you on the call right now, who support Ontario Health with their clinical perspective in other ways, giving us guidance, sitting on advisory tables. And from a primary care point of view, we have, which is really exciting, for the first time, a provincial table of clinical leaders in primary care across all the regions. There are 14 family physicians who come from each of the regions, and they are there to work with the regions in terms of implementation of primary care. And they sit on a table together, which is chaired by me. And that is just another piece around the way we work at Ontario Health and the clinical side of it. We do connect in with all of the landscape of primary care. So there's a lot of different associations and organizations working in primary care. So if you look on the left side, these are some of the external primary care tables that we sit with and work with. So one is the Primary Care Collaborative, which includes the OCFP, AFTO, NPLC, the Indigenous Primary Healthcare Council, and the SGFP, as well as the Ontario Primary Care Council, which is the table where OHT leaders in primary care sit. And then on the right are some of our internal tables that where primary care is the focus. I won't go through all those. Next slide. So this is, to me, the big picture of where we're trying to go, right? And I know we feel this on the left where we're at. Primary care is a sector. It's not a connected system right now. The way we're resourced, the way it's designed, we can't meet the need for access to care. And we know that that demand is only going to increase for all the reasons that we're familiar with in terms of population growth, aging population, and just the sheer complexity of care, which we are responsible for being the core coordinators of. And this is where we want to go. So with a robust, connected, integrated primary care system. So how do we get there? These are our three key objectives. I think about this as a bit of a three-legged stool. So, and again, this is focused on, I talked about what our mandate is and where our responsibilities are in Ontario Health. So this is focused and aligned with that. So the first is to expand capacity and access to primary care, particularly ensuring we have interprofessional teams that are equitably available to patients and to clinicians. Expanding capacity also means dealing with the administrative burden. because if we can reduce those 19 hours that we spend on administrative work, that gives us more time for direct patient care. The second leg of the stool is around connecting primary care, and I will speak a bit to the primary care networks because I think this is a huge opportunity for us in Ontario. We have not had an organized infrastructure for primary care to bring our voice to the table. So I think that piece is really critical. And then the third is around measurement. So that expression of, if you can't measure it, then it's difficult for us to show our value. And so I spend a lot of time internally looking at our data and being able to collect or grow the infrastructure that we require to measure what we're doing, and not just look at counts of visits, for example. And then along the bottom, this absolutely key foundational piece about reducing inequities in the healthcare system, so driven by that. If you go to the next slide. So I'm going to just talk about three particular initiatives. I think they tie together. I think they start to show the journey that we are on. I recognize, and there were some comments in the chat about this as the webinar started, like there are some low-hanging fruit here, but this is a longer journey that we're on together, and I think we all know that. But I am optimistic through pulling these threads together that we are going to see some movement in Ontario. We've seen it before, and I know Ontario Health is committed to supporting advancing us in that journey. So the first is around the primary care teams. So the community health centers have sat in terms of their who they report into and are accountable to. It has been with the LHINs, and so now to the regions. So that is a longstanding relationship that we've had with the community health centers, but now the family health teams and the NPLCs have come over to Ontario Health. And I think this provides a really exciting opportunity to try to align, as I've listed here, the priorities across these teams, to try to take a look at how do we explore the optimization of team function and expand access. There have been some really interesting initiatives where our CHCs are FITs, the MPLCs are a bit newer, but the other two have looked at how do we reach out beyond our four walls and take a look at sharing resources with practices and family doctors who have no access to teams. So I think there's a really exciting opportunity now that these three teams are with us. And I'll just point out that the Indigenous primary healthcare teams continue, and some of the more like alternate types of teams or special teams still sit with the ministry. And the next slide is the next opportunity. So this is the expansion of team-based care. You will have heard about this. So 78 new or expanded interprofessional primary care teams, $90 million worth of funding, 3 times what was initially announced by the ministry. So the people who have received the funding and those who did not have been advised, we haven't had a public announcements yet. So the MPPs have been doing some announcing, but so that I don't have a list for you of all of the 78 teams, but I think this is another really exciting opportunity. Is it enough? No, this does not address the gap, the full gap that exists in terms of access to care. But this, I would say, is we can think about this as a down payment on the journey towards expanding access to interprofessional teams. And I think what we know about the teams, back to the work conditions, is that being able to work with a team brings a better experience for patients, but it also improves the experience for the clinicians working in those teams. And there was a great study that they did taking a look at the 29 point something hours that we would have to spend as family doctors if we were really going to address all of the guidelines around preventative care and chronic disease care. And that's impossible to do, obviously. And if you have a team where you have an alignment around that work and some delegation and sharing of tasks, that we could see that number drop down to under 10 hours per day, which is also still not enough, obviously, but or too many hours in the day. But I think that is working top of scope, a team will permit us to assign, I think, the clinical tasks to the best provider and support and alleviate the burden that sits right now on family doctors. Primary care networks. I'm really excited about this. As I said, these are structures that will be aligned with and connected to the Ontario health teams. We know many Ontario health teams have already established local approaches to try to involve primary health care. And what we're doing now is, as a government, and this is across the ministry and OH, saying that if we know that primary care has to be foundational to the Ontario health team, let's start providing the guidance and some funding to make sure that that will happen. So a guidance document, and I've linked to it there, has been released, which lays out what some of those guiding principles and opportunities are. The network itself, I would say, I've listed the functions and then the clinical priorities on the other side, but I think it's two things. It's about relationships. It's about pulling us together as a sector so that we know each other, connect with each other, align the work that we're doing, and it's about action. So the network will facilitate action on particular clinical priorities. And right now, our key challenge in the health system is the unattached. And another would be chronic diseases, managing chronic diseases. I also think it's an opportunity for us to try to organize the supports that primary care needs. So whether that's practice supports to aid in implementation, whether that's digital supports, whether that's clinical supports, so programs like SCOPE, for example. So I'm really excited about the primary care networks and the journey that we can go on to organize care and primary care in the province. And I'll just quickly, I won't speak to this, this is just some of the timelines around the primary care networks. So, and highlighting that the initial 12 OHTs, there is specific funding and there additional specific funding for primary care and the primary care networks. But I'm happy to talk to that if there's more questions. And the last two slides, this one here is about, again, a shared initiative across the ministry and Ontario Health called Patients Before Paperwork. This emerged from the Acts the Facts effort and movement to try to modernize communications, and has expanded now into an opportunity to have a clinically led transformational change in how we communicate, with a focus on reducing that administrative burden and reducing provider burnout by trying to align the digital supports. So these would be things like e-consult, e-referral, prescribe IT, many of these, the scribes, AI scribes, for example. So we're excited about this and what this will mean as we start to roll out a more, I would say, bundled approach to these digital services, so that you're not getting individual services sent to you, but in fact, it comes as a collective. And delighted that Claire Liddy, who is a family doctor, has agreed to be the provincial lead to support this program. And my last slide is here, which is to just say that on the right are 10 of the in fact, 11 foundational pieces required to advance primary health care. So there's no one thing. Primary care networks on their own, family physician remuneration on its own, teams on their own are not going to get us to where we need to be. It's a journey across many layers to move primary care forward. And I think there's an opportunity for all of you, if you're interested, to be engaged in this. As a first start, I really would encourage you to reach out to your Ontario Health team and become involved in the primary care networks. And you probably have some structure that exists right now, or may not have that. If you do, you could start with that if there's something that exists. And if not, then engaging with your OHT to get that moving. And as I say, I'm optimistic about the journey that we're on, and look forward to I'll speak to speaking to some of the questions that might come up. So over to you, Eleanor. I've left my email here, sorry, and then our primary care program email. So please feel free to reach out to me at any time.
Thanks so much, Liz, for bringing us up to speed and clarifying some of the different roles and responsibilities within the province in terms of healthcare. Yeah, thank you for taking the slides down. I'm gonna bring on camera as well, Mehele, and I'll bring you back, Megan, because I think there's gonna be a few more questions for you regarding measles, mumps, and rubella and COVID. So perhaps we'll just start just because a few things came up regarding the measles, mumps, and rubella. Megan, which I think you've answered in the chat, but I thought might be good for others to hear. So one question was around, when is the measles rash, like when are people contagious when they have measles?
Great, yeah, so the period of infectiousness actually does start before some of their prodromal symptoms. So classically, we say about 5 days prior to the onset of the rash is infectious, and 4 days after onset of rash is the period of infectiousness. And the prodrome may only start 2 to 4 days before the onset of the rash, so they may be infectious before they develop symptoms.
Thanks for clarifying that. And another question that came up, which is a good reminder, was around what are the contraindications to the measles, mumps, and rubella vaccine?
Yeah, so you guys will all recall this is a live vaccine, so not safe to give in pregnancy or in women who are trying to conceive. We also want to avoid it in any significantly immunocompromised population, so solid organ and bone marrow transplant patients, people receiving chemotherapy, patients with HIV and a CD4 count less than 200. There is neomycin in the formulation, and so if there's any allergy to some of the components of the vaccine, that would be another contraindication. And then there are a couple considerations that I just want people to be aware of. So if you have a concurrent viral illness or you're receiving antivirals, it's recommended that you not give the MMR during that time. There's a few other pieces, like if a patient has a history of thrombocytopenia, you might have a discussion around that because it can cause thrombocytopenia. And then there's a few others that I encourage you to look at if you are planning to give MMR.
Thanks, Megan. And I just wanted to bring attention to a couple of things that were posted in the chat. So first of all, some helpful resources regarding the question about transplants. So Cancer Care Ontario has a statement around measles, mumps, and rubella vaccine and transplant patients. And also that we have heard from Dr. Moore that MMR boosters are covered publicly, including for those that are going to travel that are over 6 months if they're traveling to an area that's endemic for measles or has an outbreak. Yeah, well, there was one other one, just around masking. So some resources posted again, and a reminder that during respiratory season, masking in office is recommended. So Megan, I'm going to take you off the hot seat for a moment and turn things over to Liz. So Liz, first question we have here, and you've spoken a lot about teams. So can you address articles that have said teams are less efficient and higher cost than a family physician?
Yeah, I think, it's interesting. There has been a lot written about teams, and probably more written in Ontario in terms of research papers on how teams function and their effectiveness in maybe any jurisdiction. And I think what I would say is the early data on teams in terms of outcomes was, I would say, more mixed in terms of some of the clinical outcomes around, outside use, emergency departments, clinical, following clinical guidelines. And what is clear as you move down towards maturity in a team, that the data does show that teams not only are better for patients in terms of hitting some of those clinical outcomes, whether screening, et cetera, but also looking at things like emergency department use. So I think it takes time to start to see some of those changes. And that's an important piece of what we're looking at on Ontario Health in terms of how do you accelerate and optimize, if you're forming a team, how do you start to accelerate and optimize team function? I think the piece that has been abundantly clear that I think is important for us right now in the crisis that we're in is that it's going to take a team to get us out of the load of work that we have and the mismatch with our, where our HHR is right now. There is way more work than any one part of the primary care sector could do, and I think we have seen from our youngest graduates, our residents, that they want to work in a team, that having a team is what keeps them in primary care, keeps them doing office-based comprehensive primary care. So, I think that's a critical part of, I would say, what the evidence is about why we want to build this. So, and it's, what we've seen it repeated in most of the statements that have come from the sector, whether that's from the OCFP or the OMA, or building the teams as being a foundational part of supporting the family doctor, and I think also a foundational part of supporting the patient. So, yeah, maybe that's where I would. But I think some of the literature there is, the literature is broad on this. All teams are different, and I think that's part of when I spoke to what I think is the opportunity about bringing the teams over to Ontario Health is to start to look across the teams and learn. The ideal would be to create a bit of a learning health system where we can say, okay, well, where is it working well? Where does it work best for patients? Where is it working best for the family doctor? Where are we getting the best outcomes in terms of access? And how do we start to drive all teams towards that? Long answer, sorry.
That's all right, Liz. Yeah, obviously it's a complex issue, and thank you for giving us the insights. Another question just regarding, does Ontario Health separate family physicians and nurse practitioners in quotes primary care, as we're often lumped together and we are not the same?
Yeah, I think what I would say is no. I mean, family doctors are not the same as nurse practitioners. Nurse practitioners are not the same as primary care nurses, not the same as pharmacists who work in primary care. So do I think that we all need to, back to what I just said, do I think we need to be working together to try to address the massive amount of work that primary care has to do? Yes. And I think what is clear is that to do that, you need to start to have very clear scopes of practice. And I think, so these are not the same. I would also say that the place that we're in now, which feels very, this is not the perfect word. I'm saying, going to say the word antagonistic, but it's a place of, professions fighting up against each other in primary care with what we do is not good to help us move out of the place that we're in. So I think it would be the work that we need to do around being clear on what is it that a family doctor 2023 and beyond is going to be doing, and then what do we need a medical office assistant for? What is it that an NP can do? What is it that a primary care nurse can do? I think we need to really dig into that work and get clear about it. And Ontario has an opportunity here. I think if you look across the province, we were much more advanced in terms of the use of teams. So I think that that's an exciting, place for us to lead from, to say, let's start to really clarify what we want that team optimization to look like. And, I think organizations like the OMA and the OCFP and AFTO and the Alliance can help us with that. So as well as our researchers. So I think that's how I would answer that question.
Thanks, Liz. Another question around what is the cost benefit when comparing FIG, FO, FIT funding versus fee for service?
Yeah. I don't know that I can summarize the research on that, and I know there are others on the call who could do that better. I would say the cost is very clear that those family physicians working in particularly in solo fee-for-service practice have found it incredibly difficult to sustain that business model. And I think, for anyone who's working in a practice where we're trying to manage 30-40% overhead, with rising inflation, that has shown us that it's an incredibly difficult business model to sustain. So I think we have to start to look at like what are the ways, as I said, to kind of support alleviating the challenges of working in primary care. And I think some of the things that I'm putting on the table, as I said, these are part of are part of this solution, but the real specifics around like which, remuneration and which direction we should go. And I mean, as everybody knows on this call, that's like under active discussion right now with the OMA and the ministry and negotiations. So, and not something that I'm able to speak to. I'm not at those tables. We're not at those tables at OH.
Thanks, Liz, and appreciate you answering and also clarifying where OH, where the roles are for OH. One question that's come up is just in terms of physicians that perhaps might not want to join a team, is there support for like fee-for-service and the FIG physicians?
So I'm not sure what they mean in terms of support. Do they mean, are there ways to get a team, or are there, because say, for example, joining a primary care network, that absolutely would be something that we would want those practices to be doing. And, the network, the guidance that we release specifically calls out the fact that there needs to be processes in place in those primary care networks to recruit family physicians and ensure that clinical leadership includes family physicians. And that would include those absolutely who are not with a team. If we're thinking about initiatives like Patients Before Paperwork and the rollout of like bundled digital services, which is where we're trying to head to, yes, absolutely, all of that is available to those without a team. If the question was about how would a solo doc or a doc without a team get a team, I mean, I think that this is the place that we're in right now of understanding what are the models for making that happen. And so some of that is going to come through the extra funding that we have for teams. So that absolutely we have in our line of sight, like this is the expansion of teams absolutely should be about, I mean, first of all, patients who don't have any care at all. So a focus on the unattached, and then support to those practices that don't have access to teams.
Excellent. Thanks, Liz, for answering it from all directions in terms of where physicians that aren't part of teams might get involved and the opportunity, particularly, it sounds like, within the primary care network area. One more question, sorry, it's flipped out of, it was visible, but now has gone. Let me just scroll up to it. Missing it here. So hold on one second. This is a question which I think we have addressed, but I'll just pose it to you again. So if research supports having primary care docs is essential to a healthier, well-functioning population, and when health systems are compared, it is noticed that the highest functioning systems are based on a very strong primary care system. If we are to believe this, why does the ministry continue to act as though primary care docs don't matter and can be replaced with other quotes providers?
Yeah, I think I'll just pause and say, as I did at the beginning, like I am a family doctor. I know what it feels like to be in the system right now. And I know it's been a hugely challenging time to be in primary care and to be a family doctor. And so, I mean, part of that question to me speaks to the sense of not being valued. And my answer is really in the journey that we're on right now, to know that Ontario Health, and we work in collaboration with the ministry, is moving forward on some important components of making this better for primary care. So we know we're not going to advance if we don't get some organized structure like these networks to help us bring our voice to the table, our priorities to the table, to build those relationships. And that, whether you look at the UK or you look at other jurisdictions in like the Netherlands, and I mean, this part is going to be critical. I think the team expansion is a piece of that. It's a commitment to, and it's a much bigger commitment than what was initially on the table. As I said, it's a down payment, but I think that's the journey that we're on towards expanding those teams, and a recognition that that has to be a critical component. and the administrative burden I spoke to, and I think so. I think we, yeah, my hope would be that you see in this the future, and my commitment and my optimism, frankly, that we're moving in the right direction. I know it doesn't feel great right now, but I can tell you that in my work every day, I bring to the table at Ontario Health, and it's through my own experience and my time, with great privilege of being the OCFP president for 2 years. I bring to the table your stories, and if you're, really would ask if you want to engage with me, reach out to me. I will share with Eleanor and Mehele our list of our 14 regional primary care leads. I think they are critical in terms of also advancing your voice, listening to you, and advancing your voice around system change in each of your individual regions. So I'm happy to share that as well. So I think that's where I would go with that question, because I think I feel the reality underneath it, the emotion underneath it, the place where we're at underneath that question.
Yeah, appreciate your answer, Liz, and acknowledging the space that we're all in, and the frustration many are feeling, and also the work that's happening, and that we're all, we are all family physicians here on this call and in these different organizations. And one thing I just was going to pick up on, you did talk about some of the administrative burden, and I know the OCFP has been doing some work in that area. So I might just ask Mehele to speak to a few of those things. This might be our last question before we end off, but turn it over to you for a minute, Mehele.
Yeah, sure, Eleanor, thanks. And I think I also just want to echo some of what Liz said. And, I think we're seeing a fair amount of frustration and anger. And I know that after years and years of primary care really being underfunded, it makes sense that that's how people are feeling. I know I feel it often. And, in my role, we often hear from family docs who really are struggling with the stress of trying to manage their practice, but then also sort of manage the business aspects of running a practice and the rising costs and all of those issues. And I think one of the issues that you've touched on, Eleanor, is the administrative burden. I think most people are probably familiar with some of the work that we've done at the OCFP to try to quantify that. I think we all know about the 19 hours or more of paperwork time each week. So we are doing a lot of work in this area. Some of it I know will take some time. There were comments in the chat about the centralized referral system. I know OH is doing some work there as well. We hear often from family docs how referrals are such a big pain point, and chasing referrals and trying to get our patients seen when they need to be seen really takes up a lot of our time and energy. So I think kind of continued advocacy in that area makes sense. I think the other piece we hear a lot about is HRM, and how much it adds to our administrative burden in terms of sort of the volume of reports that we see in our inboxes, as well as sort of the challenges with duplicate reports and incorrectly labeled reports. And I know there's a lot of work happening with OMD and OH on this, the HRM standards. We have continued to sort of keep tabs on this and continue to advocate for changes across Ontario so that family docs are not having to deal with sort of that burden of reports. And then we're also doing other work with the insurance industry on forms to really look at standardizing short-term disability forms. So we're not dealing with sort of multiple different forms. We've been advocating for the elimination of the need for sick notes for short-term absences, 5 days and under. I think really kind of when we look at the work that we're doing at the OCFP, we're trying to sort of continue to advocate for some of the longer term changes that are needed, while also picking away at some of the low-lying fruit that might make a difference on the ground for family docs in the short term. One of the other areas that I think most people are aware of is the CPSO changes to the continuity of care policies. And we've pulled together some tools and letter templates that family physicians can use when they feel like they're in a situation that they need to clarify with a specialist or another provider, kind of in terms of sort of role clarity, in terms of who should be doing what. And maybe I'll ask one of our team members to maybe add that link to the chat. But I think we're taking a multi-pronged approach to really try to pick away at the components of the administrative burden that family physicians are facing, so we can free up some of that time. Free up some time so that if people want to see more patients, they can, but if they just want to not have to do hours of paperwork on a weekend, hopefully we'll get to that place as well.
Thanks very much, Mahele. And it is helpful to hear about all those things on a day-to-day basis may make a difference in the clinic when we're seeing patients. I think with that, we will end for today. I wanted to really reach out and thank again Megan and Liz for joining us, for answering the many questions that they were asked, and perhaps bring up the slides again. I'll just remind people that you will receive that you can check out our recent sessions online. It's a great way to get your main pro. Next slide. And this is how you can access them. It's easy enough online. Next slide. I'll just turn it back to Mahele.
Yeah, thanks, Eleanor. As we talk about all of the great work that family physicians are doing, I would encourage you to consider nominating a colleague for an OCFP award. Nominations open on February 29th. We know there's tons of great work happening out there, and so we would love to see some nominations come through from you.
Great. And any questions? Just a reminder, our webinar recording and curated question and answer will be posted. Our next community of practice is coming up in March. And thanks again to our speakers, and thanks for everybody for asking their questions and engaging and chatting today. Have a wonderful weekend.